It's my pleasure to reach out to you. Along with me, we have a mega panel of experts joining from across the cities in India. As you know, we recently celebrated 29 September is known as World Heart Day, and India has seen a huge emergence of cardiovascular disease in spite of one of the best healthcare which is being provided from the governments and as well as the private sector. Yet we see around 31% of all deaths, which approximates to 18 million deaths in a year due to cardiovascular disease. World Heart Day is not a one-day remembrance, but a call to action, a pledge taken care of precious pump for the lifetime. Cardiovascular diseases accounts to more than 2.17 trillion healthcare cost in India alone. Today, we have Shri Love Verma, former Secretary to Government of India, Departments of AIDS Control, Ministry of Health and Family Welfare, and as well as former Health Secretary to Government of India, Department of Health and Family Welfare from 2014 to 2016. Dr. Verma, Shri Verma, sir, has been an experienced administrator with a deep experience in health sector. He retired as a Union Secretary of Empowerment of People with Disabilities. We welcome you, sir.
Thank you.
Joining along, we have Professor Shiv Kumar Shankar Utture. Dr. Shiv Kumar is a member of National Medical Commission, Medical Advisory Council, and as well as President of Maharashtra Medical Council. He has been an educator all his life. Before he stepped into administrative responsibilities as a doctor, he was also a recipient of BBMG Mahatma Gandhi Award at the British Parliament, London in 2020. He has been awarded IMA National Corona Warrior Award 2020, AKN Sinha Oration Award in 2019, and plethora of different national and lifetime awards. He's been actively engaged in delivering multiple orations and lectures in different medical organizations in India. Joining us, we also have Dr. Bashi Veliuddin, a cardio-thoracic and vascular surgeon who over a span of 30 years have performed more than 15,000 cardiovascular thoracic surgeries. He is pioneer in beating heart coronary bypass surgery, arterial grafting, and he's one of the most experienced surgeons in India. Also joining us, we have Dr. M.K. Das, Mrinal Kranti Das, joining us from Calcutta. He's a senior professor, a consultant at Calcutta Institute of Medical Research, and he has been immediate past president of the prestigious Cardiological Society of India, which was formed far earlier than American Heart Association, which is a pioneer of delivering the key guidelines all across India in providing the healthcare. We welcome you all, Doctor.
Thank you.
Thank you.
So, Doctor, I would start with Verma sir. Verma sir, recently we have seen Ayushman Bharat Digital that has been launched by the Government of India in terms of providing a unique identity. But the Government of India's primary investments and the focus always have been a free universal healthcare all. Do you want to comment on it?
Yes, in fact, if you read the policy statement which came out in 2017, universal health coverage is the aim, and towards that aim, the government has promised to spend 2.5% of the GDP by 2025. Now, let us hope that the policy gets implemented in letter and spirit, because we have not seen that increase in the healthcare budget which was expected, especially in the wake of the pandemic. So maybe in the next budget, I hope to see government, making good on its promise in the policy.
Absolutely, Doctor. Absolutely, Verma sir. So we have seen a fair financing of the cost of healthcare in terms of equity. There are two aspects to it. Even though when we go for a universal healthcare, there is a certain cost part of it that is taken over by the government. But there's another part of it which needs to be borne by the patients. How do you think that the burden would affect them, if at all it has to be?
Actually, OOP, which is out-of-pocket expenditures, is only high in India, and it goes up to 70% at times at different places So that is one aspect which has been challenging the government, and in fact, Ayushman Bharat is a response to that. The insurance part of it is a response to that, as also the idea of preventive medicine, which is there in the health and wellness centers. So far the the focus has been on curative medicine. But now if we get the health and wellness centers refurbished and running as the vision is, then the accent will be more on the preventive side. And even things like yoga will be introduced at the health and wellness centers. So at the moment, the OOP remains high, and that is the challenge before the government. Let us see what new and innovative ways are taken up by the government to tackle this. I welcome Ayushman Bharat, and I hope that there are other schemes also in the pipeline.
Correct. You rightly said, Doctor, that the health and wellness centers, which can be a game changer going forward, and there is a huge investments coming in the rural aspects where the people from the common risk factors which are there, like, from the consumption, the behavior aspects can be seen changing and drastically reducing not only CBDs, but also NCDs, which are happening in India. So my next question for you, Dr. Utture, you have been part of this medical council. You have been the key bridge between translating information to the government and as well as advocating policies and as well as collaborating with different governments. I want to ask you one question, Doctor. There is a collective action required, essential for this game-changing steps, because CBDs, again, they form a huge part of Indian deaths. Okay, what would be the optimal approach, not only in prevention when you are treating the patients who are sick, but as Verma sir mentioned, in terms of educating the patients who are visiting doctors or their neighboring folks about, or the ones, how do we create this kind of advocacy programs or collective approach in translating these measures?
Yeah, hello, good evening. I think what you are saying is absolutely right. But one thing you have to understand as far as CBDs are concerned is basically the load that is there in India is tremendous. Means if you just see the statistics, we have almost 272 deaths per 1 lakh population as far as CBD is concerned. And that is quite huge. And the prevalence also, if you see it, if I'm not mistaken, around almost 55 million CBDs are present in India. That is the numbers that we are seeing. Now, unfortunately, what is happening is as far as our outlook towards health is concerned in India has always been on the treatment aspect. But let me tell you, as far as cardiovascular disease is concerned, if you concentrate more on the preventive aspect, definitely it is going to go a long way in trying to conserve all your energy and your finances, which otherwise would be spent once the patients get affected by one of these cardiovascular diseases and they have to be shifted to a tertiary center. And all of us know what is the expenses involved as far as tertiary centers are concerned. Even, the studies have shown that what is the amount of finances we are spending as far as this cardiovascular diseases or on IHD and everything is concerned. And it is estimated that only about 25% really get the required treatment. And in spite of that, we are spending more than 200 billion rupees on this treatment. And if they say, if everybody who suffers from CVD tomorrow, if he is going to get the treatment, it would, the range would go up to 800 billion. So if you want to save all that, your whole, your focus should be on prevention of this disease. And I feel this is where the whole medical community comes into play. And as you know, even in our formative days when we are taught, I think we are the only profession which is taught prevention, which otherwise would go against what we would otherwise be earning as professionals in the future. We always believe that prevention is better than cure. That we have been taught. And here, if we can, basically all of us know what are the causes of these diseases. Obesity, diabetes, uncontrolled diabetes, hypertension, cholesterol levels, etc. And the lifestyle changes and pollution. So if there is some way we can control all these things, definitely to a great extent, we can prevent majority of these patients going on for cardiovascular disorders and trying to spend so much of money on the tertiary care. And this is where I feel, especially in India, since almost 70% of the expenditure, as Love Verma sir said, is out-of-pocket expenses, and only 30% is by the public health sector. So if we can get together and try to achieve this goal, definitely it will go a great extent in, especially we'll talk in after later on of how many man hours are lost because of getting affected by this disease, along with not only deaths what we are bothered with, but also the lifestyle changes that a person has to do once he has been affected by this disease. So if we can definitely do that, the whole medical community and the government coming together, especially public awareness programs of what you should eat, what you should not eat, the salt intake, how you should control, and then from government's part of, they can also come in with banning some of these foodstuffs which are there. If they can do that, it would definitely go hand in hand in trying to control this disease.
That's absolutely true, doctor. You mentioned the fact that we need to pin it down, and we have Dr. Bashi here, and as well as Dr. Minal Kanti. So, Dr. Bashi, I have one question for you. You have been doing, on an everyday 3 surgeries. So is Dr. M.K. Das. How many of these are the ones who would have been avoidable at let's say there is a surgery which is coming to you, had the habits changed like 5 years, 20 years, 15 years back, that this could have been avoided? How many percentage of such cases do you face every day?
Thank you, Faraz. So it is very difficult to give a percentage of the people who are coming for surgery, because most of them, this coronary artery disease affecting older people with high incidence of diabetes in our country. So once they come, they already have got advanced disease. Now my lookout is, Dr. Shivakumar has mentioned. See now, I joined cardiac surgery 42 years ago exactly. So when I started, a patient surviving after cardiac surgery was a very big news. Today, a patient dying after cardiac surgery is a very, very big news. So much we have gone ahead in developing and producing results in our country, which was not there. So we have raised the bar of the treatment. Because I remember giving letters to patients to go to US when I was in CMC Vellore, coronary bypass surgery was not done in India. Now, people are coming from that was my wish actually. When I became a cardiac surgeon, I should stay in this country and then, and get people from other parts to come to our country. Now, the important thing we have to, in cardiac disease, I find in a country like India, we should have the prevention which should start from the school itself. See, like a school health good program, because when you catch the children in the school, it's a primary school onwards, the awareness of the heart disease, the problems with smoking, alcohol, lack of exercise. And if you decentralize, if it's a government, central government, of course, our state government, central government all work together. But central government, if there is a policy, this has to be done. And the state government health department execute this as very important. See, if you look at, because I come from a village in a primary health center, so much of work they are doing. So much of children's school, they conduct programs weekly. Then they do the checkups for the students and educate them with the problems which we face today, the lifestyle diseases. So children should be, so we will be able to develop a generation in another few years, or a few decades, who will have less amount of heart disease. Already, the particular generation already has been exposed to so many things. It should start earlier, the better. That is the preventive program, which should be emphasized. The best is to continue and the colleges and everybody, the awareness of everything, the importance of exercise. And also when somebody in a family has got heart disease, they should be more aware of this thing. Or somebody has got diabetes, how to control diabetes. And the health care has developed so much. I'm sure every nook and corner we have laboratories, scan centers, echocardiogram. It's unbelievable the evolution of improvement which I have witnessed in my career. So today, to answer to your question is very difficult in the sense how many can be prevented. I don't think many of them could have been prevented, maybe 20 to 30% if they control, because 90% of the patients come to me are diabetics. And it is because the lack of awareness. And when I see 10, 15 patients a day, I yet to see a patient who is fully controlled with the diabetes. Either the HbA1c will be very high or fasting sugar will be 200 and they don't care about that. So that is diabetes is one of the number one cause of increased amount of heart disease in our country, a lack of control of diabetes. It is very because people go for alternative medications and none of them produce a proper glycemic control.
Absolutely, doctor. What you mentioned is clearly something which I concur with. 90% of diabetes patients coming to you. Dr. N.K. Das, you have been a president of Cardiology Society of India, which is the largest body of cardiologists serving in India. You have done tremendous amount of research yourself and as well as an institution in educating and bringing the latest guidelines for the doctors. I want to understand, you are being a cardiologist, a patient, but the journey of the patient is they would visit a physician's first. Once the physician sees some kind of ECG turbulence or related, they would suggest to a cardiologist. How can this partnership be leveraged so that there are early identifiers of the risk factor associated with these CVDs? And if we have to do it, what is the kind of a role which needs to be played between cardiologists and physicians and as well as medical council and the government in the co-management of the cases?
That's a very, very important question. In fact, as Mr. Love has already highlighted that initially, even Cardiological Society of India was busy in updating the knowledge to the doctors, cardiologists, that we should treat the patient rightly, and accordingly the things were, CSI was actually busy with the treatment that is called as secondary prevention or tertiary prevention, whatever you call it. Only recently actually for say 10 years or 12 years or like that, CSI is now embarking on the preventive aspects of cardiovascular disease management. In fact, when I was the secretary of the Cardiological Society of India, we took up one study that is known as CHRIS, C-H-H-R-I-S. So CHRIS study was based on basically studying the young school children of different schools in West Bengal, where both the say lower middle income group of schools means not catering to the high class society people, students, and also the high class catering schools were taken up. And there we found a very remarkable finding that in the group where the low socioeconomic status people were being schooled, and they actually had higher obesity and higher kind of hypertension. Rather than that, in the high income group of schools. Now, what we found out during that study, it was very interesting to find out that the junk food and junk preparations were more prepared in the lower socioeconomic group of schools, and that's why they had obesity, they had a little bit of hypertension also developing in the young school children. So what we tried to do with that kind of study, we did two things. One is to prevent the further developing of the diseases. We advised the mothers. We also took the mothers in our study and advised the mothers that you should cook the food in this way, and you should take the care of the children in this way, that by controlling the diet and exercise, as Dr. Bashi was telling. So they were treated and they were advised. And we also asked our health care delivery system, that is our health secretary and all in the West Bengal government, that we should have some mechanism so that they actually get this by their heart. How can we do that? We advise that we should ask the students to, while they will be appearing for the examination, like the school living examination or higher secondary level of examination, they, while filling the admit card, they should give a small test, and we should know how they are doing with the test. And in that way, they can be informed much more and they can be involved much more. In fact, in the second study also, we found a little bit of benefit with that kind of counseling to the mothers as well as children. And now we have not yet taken up the whole thing in the whole country. That is the pan-India level. We did not undergo that kind of study, but we will be taking up that aspect later on. So this is one study we found out, and we are working on it so that it can be generalized. Now, second thing, we had a study in 2018-19 when I was actually the president-elect. So that time, the study actually was done in 182,000 patients, not patients, actually people who are coming on walking to the clinics or to the centers for recording the BP. And we called it as a BP survey, generalized BP survey amongst the Indian population in urban areas, not in the rural areas, urban areas. And there, our finding was very much, disappointing. We found that only 30% of people's blood pressure is controlled, and 30% people, they are not aware of their blood pressure, and rest of the people, they are aware, but they do not take the appropriate dose of medicines even after the prescription has been made. So that showed that we had actually, we the doctor community or the health, the healthcare delivery system failed in delivering the proper preventive measures. Even we could not communicate to our people in the right way. Having said that, we are trying to cover the whole menace, and we will have to work together with everyone, with the government, with the media, with the other group of people who are taking care of the people at the government level, and also at the NGO or organizational level, so that effective preventive measures can be implemented. But here is a catch, that somehow or other, in since Mr. Love is there, so he'll be able to corroborate with my findings. Somehow or other, professional organizations are not taken into the confidence as it should happen in much more elaborately. But we are trying to have the entry into the advocacy thing, but somehow or other, we are to still break the ice, and if really it happens, then possibly the preventive cardiology or preventive medicine or preventive care will have a new mileage and will have a new lease of life.
Absolutely true, Dr. M.K. Das. I think Sri Lavamaji has heard you as well on that aspect, and precisely this conversation of having an cardiology experts, medical council president, as well as the former government functionaries, where we see a headway, where is the gap which we can identify. Lavarma sir, I wanted to tell you, as Professor Utture mentioned, that the prevention, catching it early, is very critical. As you also said, Dr. Bhashi mentioned that we have progressed in terms of treating, that we are able to sustain it, and as well as Professor M.K. Das mentioned that there is we are able to do early identification and run policy, national policy program. But I understand, there is a disparity, there is an inequity between the urban and the rural areas with respect to CVD risk factors or any of the non-communicable diseases. Doctor, how do we standardize these kind of assessments all across nationally? Because whatever programs you made for 1.3 billion people, and that's a huge scale. Yes, Love Verma, sir.
Well, I would like to agree with what Dr. Das has said, and I would actually recommend that they should be part of the curriculum of school students, and not just, the catch them early part should be not just the theory part, but also practical part. How does one take one's BP? How does one measure blood sugar? All these are things which have to be taught to children at the right age. For instance, children who are in class 10 to 12, they can be taught, they can be shown how to, because there's such a lack of awareness. And if they are drafted into it, then they can help their parents out also. In fact, I am amazed to find that even adults are, unaware or very chary of taking their blood pressure, or they don't know how to take their blood sugar. It's the easiest thing in the world. But it has to be taught, and it has to be shown that this is how you do it, this is the precise way you do it. Unless it is part of the curriculum, I don't see it happening. But it can be done very easily. I hope, the authorities will watch this and consider this idea. I'm now part of the public, so I can only, I only hope that people, from ICMR and also from the education sector, they take this up and act on these ideas.
Absolutely true. Preventing it at the childhood level, I think one of the most important aspects growing up we have seen, because we are the generation who were lucky enough to have stalwarts, the health stalwarts sitting there creating policies or functioning at creating administrative, creating a very nice health domain so that we can sustain our future together in it. Professor Uttere, I have a question for you. This is something which is we understand there is a private sector in medical practice and they exist, and the healthcare delivery has been able to penetrate areas where the government healthcare has not been able to do it. But there is one key question that comes to it. What role should it be assigned to the private healthcare in cardiovascular diseases? If they're, let's say, if they're treating a CVD case, do they need to provide them an educational training to their whole family, or what is their role to be assigned? How do we delimit that? Or like how closely, or like, how far should we be it be regulated, the whole treatment regimen, because there is a varying cost coming between different hospitals based on the many other factors.
Yes, see, basically, I think as the government is doing in every other field, the PPP model that we see, the public-private participation. Unfortunately, as Dr. Das sir has already said, that we rarely ever get to see it in the health sector. I have worked on both the sides. I am in my private practice and I'm on the administrative side also. But very rarely it is that the government entities and the private practitioners really get together on one platform to tackle any disease. Now, as far as this CVDs are concerned, basically, let me tell you that there are a lot of government programs which are there in place. Unfortunately, the implementation of these programs is where there's a lot of lag behind. And as I think you must be aware that it was the National Health Policy in 2017 which spoke about getting, reducing by 25% the deaths caused because of CVD. Not only that, it also spoke about the diagnosis and treatment of 80% of the population who would otherwise be having hypertensive by the year 2025. Unfortunately, of course, 2 years have been, we have lost 2 years to this COVID problem. So I'm not sure how far we'll be able to achieve that. But then today what has happened as compared to a few years back is technology has played a very, very huge role, especially in the medical field. So just like how Verma sir was just now telling that everybody should be taught to take blood pressure. Nowadays, you don't require to teach them also. You have got electronic blood pressure machines, which you just apply it to his arm, and then you get the results. The blood sugar levels also can, nowadays, majority of our patients are doing it at their home. So if we can bring this technological innovations to the common man, and ask the common man to monitor themselves, which would be much better. Today there's a reluctance for any common man to go to the doctor's clinic, sit in that clinic, wait for the doctor to see him, then examine him. Then, of course, he has to, as I said, out-of-pocket expenses of 70% is there amongst in the private sector. So if we can, avoid all these things, and you have one person, say, even in a family, who knows how to use this electronic blood pressure machine, he can take the blood pressure of everybody in that family. And here comes the main aspect of CVDs. If you can diagnose, say, hypertension, you can diagnose diabetes in the early phase, and something can be done to control this, definitely, those patients going in for tertiary care definitely comes down to a great extent. And this is where the private sector has a huge role to play. But somewhere or the other, I think the government also has to extend that helping hand to the private sector. And if both of us, we have seen it in the COVID times, where both the private sector and the government sector came together to tackle this disease. And I think India has been one of the most success stories as far as the population is concerned, the number of patients who are affected, and the deaths, which were very, very less as compared to any of the Western countries. Why that has happened is because everybody came on one platform and worked for the people. And the same thing, if we can definitely do to, this disease, which today, as you know, that 1 in 4 deaths are because of cardiovascular disease in India. So if we can control that, not only that, you see a great amount of man-hours lost, a great amount of, young people getting affected. There was a beautiful study which was done from 1990 to 2016, and that paper came out in 2018. What did it say basically? It said that the number of deaths because of ISD has doubled within these years. Not only that, it has shown that 50% of those affected are below the age of 70 years. We always thought that, hypertension and cardiac disease were more common in the elderly. But imagine 50% of your population, which basically is the population which brings up your country as far as, the economic is concerned, as far as the day-to-day working is concerned. If they are affected, then we are going to be hit very, very badly. And if we can diagnose these at an early stage and treat it at an early stage, I think we have half the battle is won in that.
Doctor, this robust early screening and stock in health infrastructure, where we can monitor and look at the data of what is happening with multiple patients, and there can be these kind of death, the kind of losses, the kind of pain that can be avoided. At the same time, we will be building in a healthy nation. Dr. M.K. Das, I have a question for you here. Okay. So you have been part of the association where there are only, I think you have the better number of the 3,000 plus cardiologists in India. Okay, and hypertension being one of the major cause of CVDs. Again, I'm asking, how do we train the doctors, let's say, in one of the most rural areas? As a cardiology society, the responsibility comes onto your part of educating the physicians on the basic tenets, apart from their own medical school or their practice, or identifying the key early factors. How do we do this? How do we create these kind of educational and training programs for these doctors in partnership, again, in a PPP model or the government model, where all the doctors have to do a mandatory CME with respect to healthcare, cardiology related, what are the key identifiers which can be avoided? How do we leverage that, doctor? And there is a huge stress, as Professor Uttere also mentioned, the kind of load of CVDs on cardiology in India has been tremendous. How do we unburden the doctors and the cardiologists?
Yeah, it's very, very important that high blood pressure is the number one cause, number one risk factor for the cardiovascular disease. Risk factor for cardiovascular disease. There are so many: smoking, diabetes, hypercholesterolemia, then lack of physical activity. But hypertension tops the list. And that's why maximum stress is being given, was given, but somehow or other, the blood pressure being taken as the number one cause, but it did not pick up. As I told about the hypertension survey, it was a SNAP registry that 33% did not know that they are having. So there is tremendous amount of inertia on everybody's part. Now, what is the inertia level that has been reflected there? What we can do from our society or from all professional organizations, including the government organization like MMC or NMC. So all these actually can take part in the process of prevention. There are few ways. What we are doing from Cardiological Society of India is that we are giving lectures how to take blood pressure, even to the qualified doctors, including the cardiologists. Why I am saying this? Because many time what happens, blood pressure is recorded, supine blood pressure is recorded, but not the standing blood pressure. And this is left in 99% of patients. Now, what we are stressing that if you don't take the supine standing blood pressure, then you might encounter the giddiness, dizziness, loss of consciousness and fall and all this. And that might actually adversely affect the adherence to the treatment. So if you check just once that what is happening to the postural blood pressure and postural hypertension is not there after the drug treatment has been given, then automatically the adherence is increased. So we are giving all these indications to our physicians who are treating hypertension as well as the cardiologists. This is one aspect. Second aspect is definitely we have given hoardings at different metro stations. We have given hoardings at different metro cities. We have talked to the people, our cardiologist members, they talk to the people over the FM radio channel that you should do this, you should do that to take care of hypertension, to take care of cardiovascular disease. So we are doing on our part whatever is possible at our armamentarium. But having said that, we'll have to go much more further. Now, one of the ways that can be furthered is that is again to the rather a submission to the NMC, MMC, and all these things. Our curriculum is not adequate. We must admit that our curriculum that is being followed, 4.5 years curriculum, 5 or plus 1 year of internship is not up to date. It was an old curriculum that was suiting our purpose long time back. Now we have got the digital technology. Now we have got much more knowledge about artificial intelligence and machine learning and all these things. We can apply those things. Since I am involved in some of the, the digital technological aspects of working with how to take care of the cardiovascular disease prevention and all. So I know some of the aspects. Now, if we can collaborate with our government agencies as well as the medical councils, then we can actually apply the digital technology much more in a definite way and much more in a specific way and also in an elaborate way. What will happen to the consequence is that there will be reduction in the number of years of curriculum. We can train our people in much more lesser time. As you know that during the last 1 or 2 decades, the children are learning much more faster. They know how to use the smartphone much more easily. So we can train our boys, that is boys and girls, in the medical curriculum also much more faster if we use the technology, that is the digital technology as well as the artificial intelligence. Now, in our curriculum, there is no course for digital technology, no course of AI application, and there is no reward for going for innovative technologies. So if we are to incorporate this, then we'll have to do. And only medical councils can start the process, and thereby they actually can actually start the ball rolling about the change in the curriculum aspects. And then only high blood pressure, which is very common, as Dr. Utture has mentioned, is very easy to detect. Just if it is detected in the remotest center, then that can be transferred at the hub level. We can actually go ahead with the preventive aspect in much more definite way. Over to you.
Absolutely, doctor. What you mentioned, there were the key points, like, having the data and as well as monitoring the artificial intelligence. 2016 CSI published a natural NLP paper based on heart, and I think they are the proponent of AI happening in India, and I've seen the good amount of interest that is coming in. Dr. Bashi, you have been an interventional cardiologist. You have been seeing a lot of patients across. You do, there are two edge cases which I want to ask you a question on. One, let's say a doctor who comes, a patient who walks into your clinic, okay, with a certain amount of previous reports and everything, because those are not documented well, which I think the government has started doing now, which has not been tagged. Okay, and now then you have to do all those studies again, the reports to be redone to have an effective understanding what is happening. Okay, that is the one part. What is the cost aspect for the public on that? Second part of my question is, you have done plus 15,000 plus surgeries. Has it ever happened a local administration or state level administration have reached out to you with respect to doctor? You have managed to keep so much of data, and have they even taken into account what kind of studies have been done apart from your own residents and doctors?
So number one is the investigation. Nowadays, most of the patients come with, coming to me are, underwent majority of the investigations, including coronary angiography. When they come, they will come for opinion whether the patient needs an operation or angioplasty or medical treatment. So if the necessary investigations are there, normally I don't repeat another, especially an angiogram which is done in 6 months' time. We don't repeat another angiography. And basic things, so one of the problems also is for medico-legal aspect, we have to repeat certain investigation. For example, a patient who has done renal functions or other investigations which has been about 2 or 3 weeks earlier, we have to repeat it. Sometimes it may be normal also. So sometimes we are forced to repeat because of medico-legal problems. Certain investigations we are forced to do. Because as a clinician over the years, I know certain tests may not be necessary, but we are forced to do in this. That is applicable all over the world. It is nothing different here. Now, the second question is a very relevant. That is one thing which I want to speak a little bit on that. Because the number of, including myself, most of the people in our country talk about the number of operations they have done or angioplasties we have done, and have done a complex thing, and that is the news. That is more of coming in the lay press rather than in an academic forum. And another thing is, if you look at the disease pattern, the genetic pattern, the lifestyle, the diet of Asian population, especially Indians and the Western countries, is totally different. Any meeting I go, everybody in our meetings, everybody will come, so-and-so has done in the US, so-and-so has done in the UK, European study only. We haven't had any authentic studies in our country in many of the diseases. So that is, it is very, with the data, everything easy to access nowadays. I think the government must invest more on data. Then only we can authoritatively say. Now we have only hearsay about certain states doing some or certain centers doing statistical analysis. It will throw a long way, throw a lot of light in analyzing the disease. What is the response? Because the dosage of medicines itself is much less in our patients. For example, the requirement, in my experience, I'll tell you, the anticoagulants treatment. Anticoagulants, Indian patients require only half the dose of anticoagulants. I use a lot of anticoagulants for valvular heart disease, mechanical heart valves. There are patients, my own patients, who have gone to US because their protocol is to give minimum like 8 milligram of acetylene. One patient developed bleeding because I told the patient you need only 4 milligram, but they say their protocol takes 8 milligram. I have 2 patients who developed cerebral bleed because of the problem of this one medicine, an example I'm telling you. And the dosage of statins, we are giving the same amount of statins. Our body surface area is less. Their body surface area is very big. Their dietary pattern is different. So we have to really do a real study in a national base, and it should be instilled into every place. I mean, government has to invest a lot of things to collect the data so that we can give the correct treatment, get the correct information about the disease pattern. See, diabetic patients, when I worked about 3-4 years in Australia, I find, the incidence of diabetes was only 20%. Here, the patients coming from coronary bypass surgery, 80% of my patients are diabetics. 80%. Very rarely get a patient without diabetes. Plus, the disease pattern, the blood vessels are very small. They have diffuse disease. They develop the ventricular dysfunction early onset of heart disease. All this is totally different. So, coming to the number of, in fact, I was the president of the Cardiothoracic Association last year. So we have just launched, during my presidency, we have launched a national database to collect data from all the surgeons in our country, so that in another 1 or 2 years, we will have some data. Which every time when we go, we are listening. We have to also quote, for example, a patient with a simple thing, aortic aneurysm. The diameter of the aorta in Indian patient is much less, whereas diameter aorta there is high. So, but still we go when I develop aneurysm, okay, more than 5 centimeters, they say. But our patients, it may be more than 4.5 centimeters, we may have to treat. So like that, it is a very, very important. I mean, I'm sure in future, it is going to happen. But somewhere, and all these things, a lot of investment in terms of research. So that is one side which we have to do, and we can also come out with a lot of data, which itself can change the management of the disease itself. The investment of the disease itself will become less if you analyze what is our problem. Still, we don't have. We are only treating the cause. I mean, the effect, not finding out the real cause in a statistical way.
Absolutely right, Doctor. So I think I'll be giving a last question, because I know all the doctors, and as well as Love Verma sir has prior engagements. Love Verma sir, I have one question for you. Nationally, you must have planned a lot of policies. How do we define and establish entities with responsibility and accountability for these national programs at the state and local level? How do we go about it? Because I'm sure Professor Uttere, Dr. N.K. Das, and Dr. Bashi, they all represent different entities in their own value chain. What is your expectations and their responsibilities you feel that should have been played and they should be playing in future?
In fact, I would say that this is a black hole. The whole process of accountability is more or less missing, and it needs to be addressed. In fact, you would be aware that there have been so many initiatives to map NCDs and also CVDs, but they've all come to naught because they have not been implemented properly. As everybody has been saying, that there are gaps in implementation. So we need to make people responsible from top to bottom, from the ASHA worker on to the DG of health operations. I mean, each cog in the wheel, what is the responsibility and what will be the consequences of not fulfilling that responsibility? Unless that is mapped and thoroughly enforced, I don't think these policies will be successful. One more point I would like to make is the role of the media. The media should actually play a very supportive role. For instance, I don't see, like medical columns can be introduced in our leading newspapers. All our leading news channels can have a separate health show. All these things need to be done in order to shore up the work of the government, because it's not just the work of the government to have, awareness, awareness and advocacy is something in which the media needs to be a very powerful partner, and that is missing in India today, I feel.
How about doctors, Dr. Lavarma, who are loaded with these CBD cases?
Well, doctors, there's a lot of challenge we've been facing as far as the system is concerned, even getting the doctors to go to the rural areas. We know the shortages of doctors as far as CHCs and PHCs are concerned. So I think, first of all, we have to ensure that they go to the place of their posting. That is the number one challenge before government. And for that, I think technology is very useful. Now we have systems where they have to report via WhatsApp and whatnot. You know, they report the fact that they've arrived at the PHC and biometric. So I was saying that technology is going to be a very big partner in enforcing the presence of doctors.
Releasing you, sir. I think I'll be back to you once you have a little stable network. Please go ahead.
Yeah, the connection is unstable for some reason.
Not a problem, Professor. Lal Verma. Sir, then I have a Professor Otture. I want to ask you a difficult question, and this is a final question for you, Doctor. You have seen the translation of the national policy at the state level and the implementation. And there has been, as Lavarma sir mentioned, there are a lot of cardiologists or specific doctors who are not ready to visit. And as well as Dr. Bashi earlier had mentioned that the guidelines in India are not more of a data oriented. And I think Dr. N.K. Das has taken a point of it. There is a disparity of the international care and the Indian care. How do you think Medical Council plays a role here, Professor Otture, in disseminating a new model which you can create in terms of CVD prevention, and as well as providing access to technical assistance to doctors like, Dr. Bashi Veludin or Dr. N.K. Das with respect to the data for forming effective or effective guidelines?
See, basically, yeah, there are two aspects to whatever we are talking about as far as the future is concerned. One is, as everybody is saying, is the data collection. Unfortunately, there is no comprehensive report at all on the trends of the prevalence, deaths, or disability because of the CVD, made by individual states or made by the nation itself. So that studies have not been done, as Dr. Bashi sir just now, said, very frankly, he said. Not that the government is not taking cognizance of all this. Like, just to give you an example, there are so many, acts and so many rules and regulations in place. Just to give you an example, now we have that, we were talking about prevention aspect. We have what is known as the fat, I don't know if everybody knows, the fat tax by the Food Safety and Standard Authorization, which was there in 2017. It was there in place, but what about the implementation of that? There was an advertisement ban on food which is high in sugar, salt, fats. Are we seeing that on the ground level? No. So, the administration is taking cognizance and putting in place the rules, regulation, but the implementation is something which is not taking. The National Tobacco Control Program of 2007, but you see, the tobacco companies and their shares going up day by day. So that means their consumption is going on increasing day by day. So where are all these policies going? So somewhere we have to take care of implementation of these policies if we want to really work on the prevention of this disease. Then coming to a very important part as far as data collection is concerned, I would just like to mention over here that one of the data of finding out especially deaths due to these diseases is the medical certification of death. This is something I think even all the doctors have to be retaught of how to fill that data as far as the medical certification is concerned, because that is going to tell us tomorrow what is the prevalence of mortality in these and where we require to concentrate in the future as far as control of these diseases concerned. Because CVD, as you know, encompasses a lot of things, but out of that CVD, IHD is one of the most important aspects. But today we really, as I said, 1 in 4 deaths is just a general figure that we say. But in India, we do not have that data as it is seen in any of these Western countries. So collection of data is most important aspect. Then as far as what Love sir said, I think I'm at the other spectrum where doctors have to go to these rural, that we have always been having a dialogue with the government, where we always say that if the government takes adequate care to put the infrastructure in place for the doctors to go and really work over there, I don't think doctors will not go over there, because you see today that even amongst the doctors, there's a lot of unemployment which is going on. And this can be seen because whenever there is, any of the government jobs are being advertised for jobs which are about 500, 600, you have got more than 1 lakh of people who are applying for these jobs. That means the jobs they want. But you have to have this infrastructure which has to be in place. Unfortunately, right in the beginning, I think one of the panelists said that the expenditure on health is so abysmal as compared to any other country, especially when we are calling ourselves now going from underdeveloped to a developed country. So how much are we really putting in money as far as health is concerned? And unless you do that, and today even whatever money is being put in the health is basically going into making the payments, the monthly payments of the personnel who are there with the health. So are we increasing the infrastructure? Are we increasing the environment for the doctors to really go and practice? So today, if you ask a postgraduate student to go to a small PHC center, and there if he is told that the only tablets available to you is paracetamol and a few of the antibiotics and all, how is he going to be really interested in going and spending 1 year, even if we say that he's supposed to, these bonds, he's supposed to fulfill that? So I think it has to be a two-way traffic. It cannot be a one-way traffic. The administration also has to take care that they create that infrastructure. And then, of course, I think that the next responsibility would be of the associations and the councils, the medical authorities, to see that there is equitable distribution of the health personnel in all sectors. And when I say health personnel, I don't mean only doctors, because we are always concentrating of paucity of doctors, but who's looking at the paucity of the nursing staff, which is, if you see in the Western countries, majority of the duties in such PHC centers is taken over by the nursing staff over there. But here you find that we do not have that many nursing staff because we do not have that many nursing colleges over here. So how are you going to create that? Then you have the paramedical staff over there. You require technicians over there. So how, like we were talking about hypertension, taking blood pressure or taking an ECG. You do not require a doctor to take an ECG, but you require a doctor to interpret that. And in today's world, where even the National Medical Commission, for that matter, and even Maharashtra Medical Council, we were the first ones to allow telemedicine to take place. Today, let us make use of the advances in technology, where you do not require to doctor to be present over there to diagnose a condition. He can be sitting miles away. At the same time, once he gets the data, he can come to some diagnosis, and at least he can give the basic treatment to that. Online he can give the basic treatment, so that the patient has time to at least reach some tertiary or secondary health facility over there. So you have to make use of whatever is available to us, especially in the modern times. Technology plays a very, very, very important role in the future. And let me tell you, we have learned to live with technology during this COVID times. I always like to see the silver lining on the dark cloud. And one of the silver linings on the dark cloud as far as COVID is concerned is all of us in every field have learned how to use technology to our advantage, especially in the medical fields, because I'm finding more, even education, if you see medical education, which we used to have CMEs, continuing medical educations, CPDs, where you had to be physically present to hear the lectures from the experts and in that field. But today, what we are doing now on Zoom, just to give you an example, in the Maharashtra Medical Council, we had a special program in the initial phases of during the COVID period last year in 2020, where we called the experts from all over to talk on different aspects of COVID. And you won't believe it, we had 36,000 delegates who had logged on to that Zoom platform. So this is the technology which can help us in the future, even in the primary treatment of or at least diagnosing of some CVD problems in all our patients. So I feel we can make use of that, and it will go a long way to help us.
Absolutely true, Doctor. What you mentioned, that the PHC level, and as well as Verma sir mentioned that it's something that needs to be strike the right balance. And now the given technology, digital technology has come. Even the trained the paramedical staff, the technicians would help catering to the remote areas. Given our telecommunication infrastructure has gone like way ahead for what it was 10 years ago. Dr. Bashi, a last question for you. As Professor Utture mentioned, as well as Dr. Love Verma sir mentioned, that there has to be there has to be a training not only to the cardiologist, like you being a director of cardiothoracic surgeries, and you have been in the catchment area of Chennai, to have those kind of skilled paramedical staff and technicians. What is the amount of training that is required, and how can we adequately bridge the gap? Let's say, since smaller centers are located in smaller towns where the people can access SIMS hospital and your own expertise via telecommunication.
Like the telecommunication advance which has happened, as previous speakers have mentioned, has really made the world very narrow. So especially in a cardiac unit, we need a big team of people. Like we need the perfusionist, we need the anesthetist, we need the technicians who can run the pump, and the anesthesia people. So many, and in the ICU staff to look after the patient. All those people, the physiotherapists. These are the main people who the paramedical staff involved. But most of at least in Chennai, we have a lot of centers are there training these people. We have adequate facilities to train them, because the problem is, these are all highly specialized fields. For example, a person running the heart-lung machine, if he's not very sure of what he is doing, whatever operation I do is going to be wasted. So they have to be given proper training. But one thing which has happened now is, of late, in the last maybe 5-6 years, I find that a lot of hospitals are starting these training courses without adequate facilities. See, suppose you have you can train 2 people, they take about 6 or 7 technical people. It's very difficult to train them. So we are trying to cut down, tell the people that we should give them very good training, so that then only they can do a good job. The one of the things which have all over India which ignored is there is no quality control for the training. Because if you look at training centers in any paramedical, including nursing colleges and all, I know that certain colleges are there, but they don't have some nurses or paramedical staff. They would not have seen a patient, but they have a degree. So one has to have a real, the standard on like what happens in every other parts of the world. For example, a perfusionist, you have got 4 years training. He should be a graduate. He should have good knowledge of science, physiology, and everything. And properly trained, they will do a good job. So in every field, it is happening, because even for if you look at the training of a cardiac surgeons also, and I am sorry to say that we don't have a say in having the number of candidates to be trained from every year. So like when I worked in Australia, they train only people who have enough job. Suppose there is no job in a particular hospital, they will cut down the number of trainees. No point in training so many people, and they will be without having a job. Jobless people it will be finally. So that standard has to be kept in training program, which has not been strictly followed in many medical and paramedical fields in our country. So then only it will have a uniform standard which will raise the standard of care which we deliver.
Okay. Thank you, Dr. Bashi. And I think I'll be having a last question to Dr. M.K. Das. Then I'll let Lavarma sir finish his speech, like in his closing remarks. Okay. So, Dr. M.K. Das, you have seen Professor Utture mentioned, as well as Lavarma sir mentioned, as well as Dr. Bashi mentioned, that the doctors, the cardiologists, are not ready to go into the rural areas. Professor Utture mentioned that there is, like, the doctors are planning to go there, but there is infrastructure challenges. The infrastructure challenges not only are what Dr. Bashi added was the training aspect of the paramedical and nursing, and as well as technician staff. You, as an important and key stakeholder for the CSI, what are the measures have you taken, and what do you envisage in future that can be done to bridge this gap, to have patients, to have the paramedical nurses, and as well as the well-trained technicians who have been identified and trained are placed at the PHC levels, or they are being provided for any, let's say, or run a program for the doctors who are, or the nursing or paramedical staff at the PHC level?
I think it's a very much complicated affair right now, but what I can suggest that or what we are doing right now for training our own students, that is, who are undergoing DM or DNB course in cardiology, we are having regular meetings, regular conferences, and not only that, we are having teaching programs. So we are involving faculties from different parts of the country, and we are having, say, 400 to 500 students are being taught. They are being taught how to appear at the exam, how to clinically examine the patient. And we are doing these kind of exercises for last, say, 4 or 5 years. And this year also we had this. Even in the annual conferences also, we are having this. So this is for the specialist purpose. And for the nurses and this thing, these are these technicians, these are the things which are being taken care of by the hospitals, whether it is private or government, and they are having their courses, and naturally the doctors are involved and cardiologists are involved, and they are giving their training. And when they are coming with us during the time of intervention or doing during the time of non-invasive cardiology, so they are being trained, and they are not only being trained on all these aspects, they are being continuously being undertaking the various kind of measures that are to be taken from time to time in the form of continuous medical education. These are routinely being done, but to send them and to ask for more people at the PHC level or down at the downward level of the healthcare delivery system, it is totally a different ball game. It will have to be decided by the government agencies only, because they are the main caregiver. So they will have to decide how they will cater services to the people, and what the societies, organizations, and even the medical colleges, private or government, they can take part in those programs. Then only the number of the things, number of the nurses, number of the technicians can be increased. And once their number is getting a critical mass, automatically the things will happen in the right direction.
Absolutely. Dr. M.K. Das, as Professor Utture mentioned, the government has formed all the policies, but CSI holds a huge sway among the specialist opinion. So this is where the implementation part, wherein you can provide a certain push to all the cardiologists, because complete cardiologists in India are part of CSI. There is no exceptions except 1 or 2. You can sway that. So this is the way it helps in the implementation. This is just a random thought which I am having. I wanted to bounce it with you.
Yeah, just here I would like to mention that in 2020, when the corona started, actually we had a huge program in the form of data collection. Now, more than 160 hospitals were taken into account, and the highest number of patients were recruited, more than 45,000. And we had the data, and we published the data also regarding the STEMI care in the whole country. It's a pan-India study and huge data. And for the first time ever, this has been carried out during my presidency. And from there, actually, we had position statement how to take care of the STEMI patients during the time of Corona, where the facilities are at the lowest level because the Corona patients were to be taken care of. So we gave all kinds of indications, and we were training our own people, even if they are DM or DNB cardiologists. So we were telling that you have to take care of the patients of STEMI in this fashion. And this actually helped to some extent tide the crisis in a definite way, but this is just a small part we could achieve. Now we are extending our things from that retrospective analysis. We are now going for the prospective studies, and that will be also published sometime later on. But what I would like to stress upon, that GDMT or guideline directed medical therapy is very, very important, and that one can make a great swing. That has been shown in the East European countries studies. Now they had really bad kind of cardiovascular disease management, but once they came in under the guideline, under the European Society of Cardiology, and they ultimately took up the guideline directed medical therapy, there has been a huge improvement in the cardiovascular care. Now in our country, though we are a federal government, but we can have the same experience replicated here. But somehow or other, we are not having the advocacy power. That is why guideline medical directed therapy is not possible right now. If we can attain that power, that is the advocacy, then possibly we can, what one of our speakers has said, that the quality treatment can be assured. That can be achieved when we have the advocacy and we can implement the guideline directed medical therapy.
Lavorma sir, I would like to have your closing remark, and as well as respond to Dr. M.K. Das. He made a very critical point, like, having a guideline base. See, I know you're a former health secretary. You have like the kind of exposure you have, so that would be a very nice guiding light for every other doctors who are watching it, and as well as all the empaneled and honored experts, and your viewpoint on it as well.
Well, there are already SOPs for a variety of procedures, and also standard, standards of care which have been prescribed. So I don't think the prescriptions are missing. It is a matter of implementation. And another thing which I think got blanked out because of the bad connectivity is that I wanted to call on the media to be part of this Jan Andolan, as we can say, mass movement in the shape of weekly columns, weekly news. The news channels can also run a kind of weekly program. All this is necessary in order to beef the efforts of the government, because government itself cannot make too much of a difference. So that is something which I would like media partners to take note of. I think we've already overstepped the time, so yes, we should now perhaps take questions from the audience or whatever.
Because we already pushed our time, Doctor. I just will have a closing remark from Professor Utture, and we'll end this panel discussion. I know there are a lot of questions coming in here, but I don't think we have already pushed by 15 minutes.
Basically, as I already said, that data collection for any successful endeavor as far as health is concerned, the basis is the data collection and the implementation of whatever, after you have collected the data, whatever study has been done, the implementation of that. And, again, I would say that the government is going in the right step. If you know, recently NDHM has been, the mission of, National Digital Health Mission has been launched. Now, I have been involved with this right from day one, because the councils were involved right from drafting this whole policy and everything is concerned. So if we see the future, what I envisage is, if this NDHM really becomes successful, you are going to have the data at the click of a button, like what you expect it to be in the future. Now, again, here I would like to say that this will happen only if the implementation all over India takes place in the proper manner. And the doctor community also wholeheartedly supports this DHM. Once the data is in hand, then of course the policy decisions can be done. And here again, my request to the government is that whenever a policy decision is done, you have to take into consideration and the opinions of the organization. See, in the organizations, you have got senior members who are sitting over there, who their whole life they have spent in treating the Indian population. You cannot have a policy decision depending on what is written in the Western books, because as Dr. Bashi and Dr. Das both said, there is a vast difference between our patients and what is seen in the Western countries. Unfortunately, because we do not have the data, we are following whatever the Westerners are doing, which is not good for our patients. So then they have to take the opinion of all the stakeholders in the health sector whenever they come out with any policy decision or drafts in the future. And if that can be done, again, I repeat myself, the PPP model is the best way to treat. COVID has taught us that. So if that can be taken, where we go hand in hand with the policy decisions of the health, policy of the government and the private sector organizations helping the government out in making these policy decisions, I think it would be a win-win situation for everybody. And ultimately, it will be to the advantages of all the patients who will get the best of treatment and the best of policy decisions made by the government.
Thank you, Professor Utture. Even we have Dr. M.K. Das here, who mentioned then there are a lot of questions coming in, but I would not be able to take those questions today. A few of them are controversial as well. One of the questions from Jabalpur has come in asking whether can we open cardiology for non-allopathic doctors, because we face a huge stress demand. I am pretty much confused who to share that question with. We have Professor Utture and Love Verma sir here. Innocuous it might seem, but yes, there is a kind of dearth or a stress need of cardiologists. What is your viewpoint?
I think I would pass on that because it's a very technical question. I would leave it to the good doctor to respond to that.
Professor Utture, Dr. M.K. Das, you would like to respond?
So your question is that how can we build up more
capacity building? One of the questions from Jabalpur, it has come, why don't we allow non-allopathic doctors the training in cardiology?
Yeah, there are certain problems. Actually, science deals with 4 pillars. First is hypothesis, or you have to postulate, and then you have to experiment, then you have to observe the result, and then you have to infer and implement. So these are the 4 steps of science. Now, if as a say allopathic practitioner like me or Dr. Bashi, we are treated we have been taught in that way that there are 4 pillars we are taken care of, and whatever we are doing based on that scientific basis. But we are not sure about the other kinds of treatment. I think government is much more knowledgeable about this particular aspect, whether the non-allopathic medicines or they are following these scientific principles or not. So training them in a very specific way will be a difficult problem. But what we can train, how to check BP properly, how to check heart rate properly, or pulse rate properly, because there is a difference between pulse rate and heart rate, mind you, if there are problems in the heart. Pulse rate is not equivalent to heart rate. Heart rate is not equivalent to pulse rate. Now, how I am going to explain that why there is discrepancy if he does not know what is arrhythmia about? So there are certain problems in treating them, but basic things can be taught. This is number 1 way. And number 2, if somehow or other we can implement implement the digital health mission in a better way, and we can have our data accumulated, then possibly we can take up the things in that way that we can give some of the informations to them so that they can act as a sort of delivery system. So they will be delivering this without thinking about the what is in between, what are the fine prints between this. And that can be possible only with the application of AI. I somehow or other went to China. I saw there how they are applying the AI in a very, very great way. Fenshangang is a state rather. So they are employing all kinds of digital technologies, right from the entry of the patient to the hospital to giving the prescriptions and all. So there many steps are not taken by the doctors. They are being done by the commoners. And if that commoners or say some knowledgeable persons are given those responsibilities, it can be done. But the deeper aspect of the hemodynamics, deeper aspect of the arrhythmogenesis, deeper aspect of the cardiac arrest cannot be taught in that way. Though it's not very difficult, but it is a little bit unscientific in my own opinion. I'm just criticizing myself about this particular aspect.
I think I'll just take a last comment from Professor Utture on this.
Basically, I think the two words, that is capacity building, is most important aspect, no doubt in that. And unfortunately, what I find is that why are we taking the easy way out and trying to bypass what has over the years we have experienced. Now, this has been taken cognizance of even by the National Medical Commission. And today, if you see, the number of students from modern medicine, that is MBBS, who are coming out is almost 100,000 a year, nearing that much. So down the line, if you see within 5 years to 7 years, when all these doctors come out in the society, definitely whatever we are talking about, the skewed doctor-patient ratio, definitely it is going to take care of all that. So when we talk about capacity building, you should talk about the training aspect of or the qualification of that particular doctor, instead of having someone who is not trained in that. But I absolutely respect every format of medical, may it be Ayush, Ayurvedic, homeopathic. They are fantastic because we have been seeing it over years, their treatment. But then when you start mixing, the problems start. That's where the problems start. So when you talk about capacity building, let us talk about increasing the number of medical colleges, increasing the number of the medical students and the doctors who come out. Definitely, I feel that down the line, with how things are going on now, especially with the the new education policy and all coming in, down the line, I don't think there should be any problem instead of trying to take many of these shortcut procedures.
Brilliant. Thank you, Professor Utture. What you mentioned was not mixing base. Today, I think on this World Heart Day 2021, on 29th September, and we're celebrating today with all these stalwarts. And I think everyone from the value chain for the purview of doctors' education as well as for the patient awareness, we had on a panel, and I felt enlightened by the thought process of Shri Lavarma Sir, Professor Utture, Professor M.K. Das, and as well as Dr. Bashi Veluddin, sharing each other's experience and insights. And I think we can keep having these kind of discussions where we connect all the dots, work together for a common goal, because ultimately everyone's goal is a better access to the health and as well as effective healthcare delivery and as a healthy nation as we go forward. I sincerely thank all the doctors who spared time, and though we have extended by 25 minutes, Shri Lavarma Sir, who is usually very busy, Professor Utture Sir, getting his time is extremely busy, then Professor M.K. Das, who in spite of being stuck in a personal crisis, he made time for this panel, and Dr. Bashi, who keeps shying away from all these webinars, he came on. It was an amazing experience in terms of learning, and I wish to have these kind of conversations further, and that way we are able to generate a good value chain in terms of all the critical decisions we are taking. Thank Thank you, doctors, for all joining us tonight. Thank you, all the viewers who are there, who are watching there. Keep watching Omnicares. Thank you very much.